everyone. It's my pleasure to be here, and thank you very much for the invitation. So, as you know, the aim of imaging when you've got a suspected stroke patient is, of course, to confirm the diagnosis of ischemic stroke. Is also to precise the occlusion site, as you know, and in case of late-stage stroke, to determine the necrosis and the penumbra, and also if you can predict the hemorrhage. In France, as you know, we use a lot MRI, and MRI is a great technique to answer this question with diffusion, with T2 star, the penumbra, with perfusion, diffusion, and MR angiography. What about the therapeutic option for stroke? 5 years ago, in fact, it was quite easy. For distal occlusion of less than 4 hours and 30 minutes, it was TPA. And for proximal occlusion of less than 6 hours, the treatment was thrombectomy and associated with thrombolysis. But in fact, as you know, recently things have changed. And the choice of a therapeutic option is not only based on time, but now on imaging, the imaging clock. And here are listed, I think, 3 of the main publications that have really changed the managing of stroke. As you know, the Down study, the diffuse stroke study using perfusion, and it's possible to do thrombectomy until 16 hours after the symptom onset, and thrombolysis up to 9 hours after after stroke onset. The target of the therapeutic is the ischemic penumbra. The penumbra is a zone that can progress to infarction without treatment or can recover with treatment. But the difficulty, what is difficult, is to make the distinction between penumbra and oligemia. Oligemia, you will have a perfusion defect, but will never go to brain infarction. So I think one of the big challenges was to make the distinction between penumbra and oligemia. But in fact, recently, things have changed. And some other publications, some other author said some things, very, very different approach. And we can read the conclusion of this publication in the Journal Neurology, and the conclusion was in patients undergoing proximal anterior circulation mechanical thrombectomy in the extended time window, there were no significant difference in the clinical outcomes of patients selected with non-contrast CT compared with those selected with perfusion CT or MRI. So a somewhat provocative question, is perfusion really necessary today? I believe the answer is yes, of course. I think the first utility of perfusion is the diagnosis of distal occlusion. This is true for MR, but this is also true for CT. As you know, using MR, diffusion is normal in around 3 to 5% of the case. It's what we call the full mismatch. Diffusion is normal, but perfusion is abnormal. As illustrated in this case, diffusion was normal, no occlusion was seen on the angiography. You can see a perfusion defect. The patient was treated. We repeated the MR 1 day after, and you can see a small diffusion lesion. This is, can see it's what we call the full mismatch. This is true for MRI, but it's also true for CT. The utility, I think the main utility of perfusion using simple map is to detect on CT, for example, distal thrombus, which are very difficult to visualize on CTA, on CT angiography. And also perfusion is, I think, is helpful for the diagnosis of stroke mimics, as you know. What about now, and I think it's a more difficult subject, about ischemic penumbra. As you know, the gold standard for ischemic penumbra is PET, oxygen 15 PET. And penumbra with this technique is defined as a decrease of cerebral blood flow, an increase of oxygen extraction fraction, and a quite normal preserved cerebral metabolic rate of oxygen. What about MRI? As you know, MRI, the evaluation of penumbra, we use the perfusion-diffusion mismatch. The infarct core, we use ADC. For the ischemic penumbra, several publications, several authors have promoted the use of Tmax and more than 6 seconds to delineate it well, the penumbra, and in fact to make the distinction between the penumbra and oligemia. But the question is, can we really trust the estimates of infarction and hypoperfusion volumes? First, as you know, diffusion, in fact, abnormal diffusion is not a real infarct core. Diffusion is reversible, as you can see in this case. Patient at admission and after thrombectomy, no more lesions. So this is very usual. And I think with advanced MR oxygen sequence, it's possible to better understand diffusion reversibility. Here, an example of oxygen map. And as you can see, in a patient with stroke, you've got a perfusion defect, abnormal diffusion abnormality. You can see, like in PET, oxygen 15 PET, an increase of oxygen extraction fraction in the perfusion defect, in the penumbra. And the CMR02 was, in this example, slightly decreased. So what is the useful of oxygen map, what we believe, to understand the reversibility of the diffusion abnormality? Here are some examples. A large stroke with a decreased ADC. You can see an increase of OEF, oxygen extraction fraction, outside the abnormal diffusion abnormality in the diffusion, and also you can see an increase of oxygen extraction fraction in the diffusion abnormality. And in fact, what we show in this study is that when there is an increase of oxygen extraction fraction in the diffusion abnormality, it's predictive of reversibility of diffusion abnormality. And this is quite, this example is quite impressive, but it works very well. Another example here, the abnormal diffusion, here the OF map. You can see here oxygen extraction fraction is increased outside the diffusion abnormality, in fact in the penumbra. But you can see that the diffusion, in the diffusion abnormality, the OF is not increased, it's decreased. So guess, what will be the final lesion at day 6? There's no reversibility of the lesion. So I believe oxygen extraction fraction may be very useful to predict the reversibility of diffusion. So in fact, we look in our cohort of patients, we look at, I don't remember the number, but a lot of patients achieving recanalization and not achieving recanalization, because of course if you want to have reversal diffusion, you need to have recanalization. And in fact, what we show is that in patients with successful thrombectomy, in patients with an increase of oxygen extraction fraction within diffusion abnormality, there was a significant decrease of volume diffusion abnormality. So I really believe that these maps are very important to really understand the infarct core. What about the penumbra? What about the evaluation of the perfusion defect? This is an old publication, but I think illustrates well the problem of all the software. This is one patient with stroke, which was evaluated with 3 software, the penumbra and the infarct core. And as you can see, the infarct core and the penumbra are very different between the 3 software. And what is interesting, it's if we look at the final, few weeks after the final lesion, none of the software predict well the final lesion. So I think there's a lot of work to have a better evaluation of the penumbra. So I think a good technique to really evaluate software, to evaluate the penumbra, the perfusion penumbra, we use, in fact, this approach. There's two kinds of patients. One kind where the thrombectomy is perfect, and here our hypothesis is that the initial lesion at admission on the diffusion should be close to the final lesion at day 6. While, and I think this is maybe more interesting here, in patients with unsuccessful thrombectomy, no reperfusion, the hypothesis should be that the penumbra should be equivalent to the final lesion at day 6. So in fact, we will look at those patients. And that, I think if we use this approach, it's a good technique to compare one software with another software. And in fact, we did this study. It's what I will show you are preliminary results. They are not yet published. And in fact, we compare first the volume of penumbra using Tmax of Serker and Tmax of Rapid. And with this approach, if we look at the blonde at mat plots, which represent the difference between the penumbra and the final infarct, we can see, in fact, that they are quite similar. Using the Tmax approach, maybe Tmax Serker is a little better because you see the mean here, it's minus 21, while with Rapid it was minus 50. So maybe Tmax Serker to evaluate the penumbra seems better than Tmax with Rapid. But we were very impressed if we compare the evaluation of the size of the penumbra using AI Serker compared to Rapid. And here we were very impressed because the prediction of the final lesion was nearly perfect, as you can see. The mean and the median were near zero. That means that the prediction using this approach, I don't know exactly what's in this approach, but I can tell you that it's worked much better than the Tmax approach, and it can predict the final lesion in non-recognized patients. So to conclude, I think, first of all, perfusion can facilitate the diagnosis either on CT or MR for distal occlusion. And here you only need simple parameter MTT, time to peak. But of course, for penumbra quantification, it's more complex. So I think you will need a more complex parameter, Tmax, AI, and therefore maybe with a better understanding of penumbra quantification, we will have optimal treatment for late-stage stroke. Thank you.
Thank you so much for this very inspiring talk. Are there questions from the audience? So maybe I can ask one. How would this look in a clinical situation? How would you, based on your findings, propose that stroke physicians use this approach in their clinical practice?
I think it's difficult to answer because these are research projects. We don't use this in the clinical practice. We will start, I think, next week to have it in clinical practice. But I think it may be useful, for example, in large infarct core to see, I think if in large infarct core, if the OF is decreased in all the lesions, maybe you will not have a bad benefits of thrombectomy. But we will have to talk with neurologists.
Right.
Yeah.
Thank you. So question?
Do you think that we will do perfusion imaging pre-thrombectomy in 5 years? With looking at the large core data coming out now, where it's probably beneficial to all of them, even if the number of NNT going down?
I agree for thrombectomy, but I don't agree when a patient arrived it's not always a thrombectomy. In some patients, it's thrombolysis. And in some late-stage stroke, you think it will be thrombectomy, but in fact, it's not proximal occlusion, it's a distal occlusion. And I agree. I believe for proximal occlusion, you may not need all this. But I think for the extended window for thrombolysis, I think you will need always this technique. But I agree, for proximal occlusion, I'm not sure. Yes, of course. You have a proximal occlusion, you will treat the patient and you will not look at perfusion data. But maybe I think a problem, well, instead in France, is that because now you can treat thrombectomy until 24 hours after the onset. So it's a huge it's a lot of patients. And we don't have the radiologists to treat all these patients. So maybe this technique will be helpful to exclude some patients. But I'm not sure.
I have a question about the data you presented. Did you have some data on collateral circulation before? I mean, because if we are thinking about the other perfusion maps we have, about penumbra, we think about it depends on collaterals, but circular is something more. So I was wondering if there was a relation with collateral.
We made another study with collateral to make a correlation between the collateral on angiography and the oxygen parameters in the penumbra. And we also demonstrate that the oxygen parameters are much better in the penumbra when the collateral are better.